All right, let's talk about hepatitis from chapter 44 in Lewis. So hepatitis can be an acute or chronic inflammation of the liver, and depending on the type of hepatitis, and we're going to talk about A, B, C, and D, there are different modes of transmission and different clinical manifestations. So what we're going to focus on is viral hepatitis, but there are other causes, parasitic hepatitis related to drugs, alcohol, chemical agents, autoimmune diseases, and metabolic abnormalities. Hepatitis A is transmitted via the fecal-oral route. So a lot of frequently associated cases have been linked to contaminated floodwaters, drinking water, eating from a restaurant that has poor environmental sanitation. The incubation period for hepatitis A is between 15 to 50 days, and some of the manifestations during this period may be flu-like, so fatigue, anorexia. Hepatitis A does not progress to a chronic hepatitis, but the severity and the manifestations of the acute hepatitis can range from mild to severe. When the patient develops hepatitis A, this actually would confer their immunity on the individual, so they're not able to acquire hepatitis A again. So the incidence over the last several years has decreased since the creation of the hepatitis A vaccination and some of the current standards for suggestion of populations to be treated, especially if you're going out of the country. Serum testing, serology for IgM antibodies or immunoglobulins indicate an active infection. IgG, which is not commonly tested, indicates immunity, that somebody has had a previous infection. So remember those two key serum testing. So the serologic events in HAV infection, so somewhere right before the first month during the incubation period, if you check somebody's stools for the virus, they'd be positive. Somewhere between 2 to 3.5 months, the patient might present with the acute symptoms, jaundice, their liver enzymes might be elevated, and the IgM antibodies test would be positive at its peak, and that checks for an acute infection. So convalescence in the recovery period is somewhere between 6 to 12 months, and like we said, IgG antibodies indicate lifelong immunity to HAV. So hepatitis B is transmitted perinatally from mother to baby, percutaneously, so through IV sticks, IV drug use. It can also be transmitted via mucosa exposure to infectious blood, blood products, or body fluids like saliva. The incubation period is 28 to 160 days. The manifestations similar to hepatitis A in the incubation period can be very flu-like, i.e. fatigue, anorexia. Hepatitis B, in comparison to hepatitis A, is that you can develop a chronic state of hepatitis B, but that's not very likely. Only 5 to 10% of patients who acquire hepatitis B will progress to a chronic state. There has been substantial decrease in the rate of hepatitis B with the standardization of vaccinations at birth. So if we were going to do serology testing for hepatitis B, it's a little bit more complicated than hepatitis A. There are 3 surface antigens that are specific to hepatitis B, and there are concurrent antibodies that can be tested that target these antigens. The ones that you need to be aware of for your test is the antibody HBs, which is a surface antibody. And this would indicate lifelong immunity. So if somebody received the vaccination, active immunization. So over 12 million people annually are infected with hepatitis B. but only about 1 million will develop the chronic form of hepatitis B. If they do, about 5 to 20% of these patients will die. So some of the high-risk populations that can acquire hepatitis B is via sexual intercourse, even through kissing, anything where saliva or body secretions can be interacted. Household contact of chronically infected patients. Hemodialysis patients are high risk as well, and most likely because their immune system is suppressed, so they could acquire an acute infection and then very easily progress to a chronic state. Any healthcare and public safety workers, transplant recipients, and I think just a key point to know is that hepatitis B is much more infectious than HIV, as it lives on the surface, a dry surface, for more than 7 days. So serologic events for an HPV infection. So the incubation period is a little bit longer than HIV. There are, in the beginning, during that incubation period, surface antigens, and the E antigen would be positive, as well as you're going to see the viral load of the HPV, the DNA. You're also going to see that. During the time frame of 3 to 5 months, well, you'll see the acute symptoms of jaundice, elevations in liver enzymes. And then over the term of 4 to 12 months, during the convalescence period, you're going to see antibodies that are going to start to develop. And then during the recovery period, which could last many months, you're going to start to see more of the long-term antibodies for the chronic immunity. IgG of the antibody HPS for the antibody HBC. The S stands for surface, and the C stands for core. So hepatitis C virus, it's an RNA virus that's transmitted through IV drug use, high-risk sexual behaviors, occupational exposure, dialysis patients, and anybody who's received transfusion before 1992. That was prior to donations of blood being tested for Hep C, Hep B. It wasn't a standard as it is now. The incubation period is 15 to 160 days. These patients can also progress to a chronic state, so you can have acute or you can have chronic. A big problem with hepatitis C is usually in the incubation or even in the earlier stages of hepatitis C, the acute phase, patients can be asymptomatic. And so it's not till many years later until they've developed liver failure or chronic hepatitis C and symptoms that they're aware that they have an infection. And so sometimes the liver impairment has progressed. So about 30% of all patients who develop chronic Hep C will develop cirrhosis. And with hepatitis C, there are several different serologies that can be tested. You can test different genotypes of hepatitis C. You can also test the viral load, which is the HCV RNA. Okay. And you can also test for antibodies, the HCV. The hepatitis D virus is also an RNA, but a delta virus that's transmitted via blood products, and with close contact. The incubation period is unknown, and the manifestations can range from very mild asymptomatic to acute failure. A key point to remember with hepatitis D is that it cannot survive on its own, that it requires an active hepatitis B virus for it to survive, for it to replicate. So obviously, when patients have hepatitis D, they're also going to have hepatitis B. There is no vaccine for hepatitis D. However, the incidence of hepatitis D prevalence has decreased since hepatitis B has also decreased since the invention of the vaccination. Diagnostics, There is an antibody that you can test for HDV, and there's also an HDV antigen that can test to determine infectivity of the virus. So the pathophysiology in the acute infection, you're going to have liver damage from lysis of infected hepatocytes or liver cells. The inflammation throughout the liver can interrupt bile flow. When the liver starts to repair after an active infection, when it's not going to progress to chronic, the liver cells can regenerate in normal form after the infection. In a chronic infection, as it progresses, it can cause fibrosis and progression to cirrhosis and those changes associated with cirrhosis. There's also an antigen-antibody complex reaction that's going to activate the complement system. So when the antigens and the antibodies form, they can develop immune complexes, and it's going to activate the complement system. So some of the manifestations when that happens is you're going to see a rash, possibly angioedema, polyarthritis, and fever. So like we said, with hepatitis, it can be classified as acute or chronic, only with B, C, but not with A. A is only an acute form. But many patients can be asymptomatic, but depending on, doesn't matter whether it's acute or it's a convalescent or recovery. A lot of patients are all going to have throughout, they're going to have malaise, very vague symptoms, fatigue, maybe muscle pains, a little bit of light joint pain. On physical exam, you're going to see the liver borders be enlarged. So you might see hepatomegaly. In the acute phase, where these patients are most infectivity, so they can transmit, it lasts about 1 to 4 months. And so the symptoms during this time, like we said, are the same that we just mentioned, but they also might have some nausea and vomiting, right upper quadrant abdominal discomfort. And smokers may find themselves having this new distaste for cigarettes. Some of the physical examination findings during the acute phase, like we said, an enlarged liver, but we also might see enlarged lymph nodes, an enlarged spleen. And you can have an icteric or an anicteric phase, so if the patient's jaundiced or they're not. If the patient is jaundiced, meaning that the bile is unable to be conjugated to the active form, or there's compression from the inflammation in the liver where the bile can't be moved out to the common bile duct, we might see dark urine. It might be tea colored because the bilirubin is being excreted through the kidneys, through the urine. Because we don't have enough bile or bilirubin in our stools, we're going to see a very light or clay-colored stool. And if the bile and subsequent bile salts start to be absorbed within our skin, within our blood system, we can have itching, pruritus from the bile salts being underneath the skin. So in the convalescent or chronic phase, this is where you're going to see if they are icteric, they do have jaundice, you're going to start to see it disappearing. The convalescent period can last somewhere between 2 to 4 months. And again, some of the most notable complaints is malaise, and they're going to become fatigued very easily. The hepatomegaly might persist, but some of the other things like splenomegaly and lymphadenopathy, they're going to subside. During the recovery period, if this patient recovers from HPV, and we also know with HIV, they're going to have lifelong immunity to those diseases. They, however, can be reinfected with another type of hepatitis, and if there's a different strain of the hepatitis, they also can acquire that. But like we said, with HIV, HBV, most patients are going to recover with no complications. They're not going to progress to the chronic hepatitis. So the mortality rate is like less than 1%, and it is highest among older adults who have underlying comorbidities. So some of the complications, obviously, it can progress to acute liver failure, most notably hepatitis C. because again, it progresses sometimes over a span of 10 to 20 years without patients even knowing that they have acquired it. So if they don't get on antivirals or some of the protease inhibitors, they're not going to be able to stop that progression to liver failure. Like we said, chronic hepatitis, highest in patients with a compromised immunity. Very little percentage of patients with HPV, but a majority of patients who have hepatitis C will progress to chronic. Cirrhosis, obviously we said 30% of patients can progress, that's in the chronic phase, to cirrhosis, but drinking alcohol, being obese, having a coexisting condition of diabetes mellitus are all synergistic factors, so they can increase the patient who has chronic hepatitis risk for acquiring cirrhosis. And a large percentage of your patients who have liver cancer, their causative factor is chronic hepatitis, about 80%. So some of the diagnostic studies, there is a separate handout that I uploaded to Blackboard that specifies different antigens and antibodies for each type of viral hepatitis. I would focus on hepatitis A, B, and C. Your liver function test, depending on at what stage or the phase of the acute infection is when they'll be elevated. So the viral genotyping testing for HPV, HCV. If patients progress to where they have a chronic hepatitis, it's going to be very important for genotype testing to be done before treatment starts so that they can curtail the treatment to the specific genotype. That's an important concept to remember. We talked about some of the physical assessment findings, the fatigue, the malaise, the organomegaly, the jaundice, different colored stools, the different colored urine. A liver biopsy is not necessary during the acute phase. However, if a patient has chronic hepatitis and we're looking to check for progression of if they have fibrosis, we might consider doing it. But you have to consider if these patients are high risk, as well as if they start to have bleeding tendencies, because liver biopsy is a high-risk procedure for bleeding. But there are other new procedures that can be done, a FibroScan, which is an ultrasound that can also assess for fibrotic changes. And then there's a biomarker called a FibroSure that can assess for fibrosis as well. Some of the collaborative care for both acute and chronic hepatitis is these patients need to be on a well-balanced diet. They need to have adequate fluid volume status. An increased caloric intake somewhere between 2,500 to 3,000 calories per day. And that's just because their metabolic rate is so high. And we want to make sure that they have an adequate amount of calories to promote liver regeneration. So low-fat diet, if it's not tolerated, if they truly do have problems with the conjugation of bilirubin, if there's a lack of bile into the common bile duct, we might want to consider having these patients on a lower fat diet, because the liver in some acute or failure cases can't store vitamins and they can't appropriately absorb the vitamins from foods. We're going to make sure these patients get vitamin supplements, B complex, fat-soluble vitamins like K, A, and E, calcium, zinc. And we also want to make sure that these patients get a significant amount of rest, especially in the acute phase. As we mentioned above, it's going to help promote hepatocyte regeneration. We're going to have these patients stay away from any drugs or alcohol that's going to be detoxified by the liver. So no acetaminophen. We're going to be very judicial with patients who get sedatives, maybe antihistamines like Benadryl, sleeping agents, narcotics. These patients should get very lower doses because we're going to have problems with toxic effects because the liver may not be metabolizing as it once was. We're going to eliminate or minimize aspirin, NSAIDs, anything that can increase the bleeding risk. And if this is acute infection, we suspect that it's been from high-risk activity or maybe from sharing a needle or from sexual contact, we're going to make sure that people that we've been exposed to before have been notified that we're positive. So drug therapy. So for acute hepatitis A, there are no drug therapies, largely supportive. For acute hepatitis B, it's only if it's advanced or severe liver failure. And then with acute hepatitis C, we don't do post-prophylaxis exposure treatment to somebody who's been stuck by a needle. But if the patient does come back positive for hepatitis C, they will start pegylated interferon within 12 to 24 weeks to reduce the incidence of chronic. Like we mentioned, supportive therapy. A lot of these patients, if they're nauseous, they're vomiting, we're going to consider doing antiemetics. So in somebody who has chronic hepatitis B, I think we need to make sure that you know there is no cure for chronic hepatitis B. We can decrease the viral load, and we can decrease the rate of progression to avoid its progression to cirrhosis, hepatitic failure, or liver cancer, but we can't cure it. We can only put it to an inactive form, but the inactive form can at any time relapse. We also want to make sure that we decrease liver enzyme levels. So those are the things that we're going to look at: viral load, liver enzyme levels, and the rate of progression as far as with drug therapy for chronic hepatitis B. There is a handout that I uploaded to Blackboard, and it's also in your textbook. Standard interferon, or Intron A, is a sub-Q injection that can be given 3 times a week for somebody with chronic hepatitis B. I think there's multiple side effects to the drug, but I think one of the biggest ones is maybe flu-like symptoms. I think you worry about leukopenia, maybe anemia, rash at the site from where the injection was given. Another one is called pegylated interferon, which it's just interferon with ethylene glycol added to it to increase the half-life. So that way the drug stays in your system a little bit longer. So that way, instead of getting the injection 3 times a week, they're only getting it once. Some other key drugs for chronic hepatitis B is nucleotide analogs. And again, those are all listed in the handout. It's not necessary to know the specific drug names, but it might be ideal for you to know how it works with chronic hepatitis, how it blocks the synthesis or the viral replication of the hepatitis B virus. So chronic hepatitis C, the goal with treatment for hepatitis C is to actually eradicate the virus and prevent HCV-related complications. So drug therapy, a little similar to chronic hep B, but different. You're going to see pegylated interferon that's also given with ribavirin, and there's protease inhibitors. So we can, because a large percentage of our patients who have chronic hep C also have concurrent HIV. And if somebody does have fibrotic changes consistent with cirrhosis, you still can treat them for chronic hepatitis C, but you just need to monitor CD4 counts in somebody who's also HIV positive, and you need to monitor for those indications of liver decompensation in somebody who has cirrhosis. In patients who have chronic hep C and are getting treatments, there's a lot of mood changes, a lot of anxiety and depression. Okay? So we need to make sure that we screen these patients prior to the start of therapy, and we're going to monitor their moods throughout therapy. So all the different things we're going to look at when we're interviewing our patients, their past history of hemophilia, history of getting any kind of blood transfusions before 1992. I'm going to look at their medications, anything that's hepatic toxic, any herbals, over-the-counters they're taking. And then we're going to look at all their risk factors and then some of the manifestations they may have presented with. So some of the more objective findings, yes, low-grade fever, especially in the incubation or maybe even the acute phase, jaundice if they're going to have it, organomegaly, and we're going to be looking at our abnormal laboratory values. If the patient is positive, they have positive antigens. Do they have positive antibodies? What do their liver enzymes look like? So our key nursing diagnoses for hepatitis is going to be obviously activity intolerance with the malaise, the fatigue. And we're also going to see the imbalanced nutrition, less than body requirements if these patients have anorexia, nausea, and vomiting, and weight loss. Those are going to be your two key nursing diagnoses with hepatitis. So our goals is to gradually at some point resume normal activities, helping them build tolerance. We want them to have normal liver function without complications. And if they're uncomfortable, we want them to be comfortable. So some health promotion activities that we can do for hepatitis A. Obviously, I would remember this because it's fecal to oral, or it's oral to anal, fecal oral route transmission, hand washing, adequate hand washing, and then adequate personal hygiene. Different places, like if you're going out of the country or if you're going to maybe shady restaurant, making sure that there's proper environmental sanitation. Making sure we've got adequate control and screening of food handlers. Patients who have hepatitis A, they don't need to be in isolation unless they're incontinent of stool. And we said active immunization can be through HIV vaccination, or it can also be through, active immunization, HIV vaccination. You can also do hepatitis A immune globulin. You can do pre-exposure prophylaxis or post-exposure prophylaxis. The only time you're not going to do immune globulin is if somebody has had the HIV vaccination greater than a month prior to exposure, or if they actually have tests that confirm immunity. If they've had a prior experience with hepatitis A and they've got antibodies that confirm that they've got lifelong immunity. Okay? So immune globulin is for pre-exposure, post-exposure prophylaxis, unless the patient has tested positive, they have antibodies because they've had the disease before, or if it's been greater than a month since they've got the vaccination. So health promotion for hepatitis B, obviously screening donated blood, identifying patients at risk who have been involved in high-risk behaviors, hand washing, using gloves, standard precautions, using disposable needles and syringes, the safety nets on some of our syringes, needles. Avoid sharing toothbrushes or razors with people, and then making sure that if you're sexually active that you're using condoms. And then active immunization between the HPV vaccination, which is 90% effective. There is an immune globulin that can be given post-exposure prophylaxis. So if somebody is stuck by a needle, they get a splash of blood in their mucosa, it should be given within 24 hours of exposure. So for hepatitis C, there is no vaccine, as we mentioned, to prevent hepatitis C. So some of the same general measures that we talked about with hepatitis B. Because there's a high surgence of baby boomer populations that are coming positive for hepatitis C in the chronic form, the CDC recommends screening all people between the ages born between 1945 and 1965. Okay. There is no current recommendations for post-exposure prophylaxis with IG or antivirals in somebody who has perhaps been stuck by a needle or been splashed by blood. What they suggest at this point is getting baseline laboratory work and liver enzymes, and then following up with a physician every 4 to 6 months to get follow-up blood work. So in the acute phase, we're going to be looking for indications of jaundice, where we have got a decrease in the conjugation of our bilirubin, decrease of bile out into the common bile duct. So we're going to assess the degree of severity. We're going to look at the skin, the sclera, the inner canthus, maybe some of the soles or the palms of the feet. The urine, is it tea colored and kind of frothy? And our stools, are they clay or tan colored? So some of the comfort measures we might be thinking of to prevent pruritus or to at least treat it. Headache, muscle aches, we might be considering more natural homeopathic remedies versus Tylenol, NSAIDs, aspirins. Again, making sure these patients have adequate nutrition, adequate fluid intake as long as it's appropriate. Since they have problems with anorexia, not really wanting to eat, and weight loss, we need to make sure that they're getting small, frequent meals, that they're in a pleasing environment where they're eating and we're not rushing them. We need to make sure that we do things to stimulate their appetite, good oral hygiene, maybe offering foods that they like, making sure the foods aren't too hot or too cold. Physical rest, as we mentioned, and this is important to remember, is essential for liver cell regeneration, recovery. So we want to do our best to minimize not only physical stress, but psychological and emotional stress. We want to assess the patient's response to rest in an activity plan. We want to make sure that they have some sort of plan where they're having scheduled periods of rest through the day. They're choosing very light activities that are going to gradually help build their endurance. And we're going to use some of the objective criteria to guide their activity. So we're going to be looking at the manifestations. We might be looking at their liver enzymes to determine if the patient is doing too much. If the symptoms are coming back, if the liver enzymes are rising, it means they're doing too much, that we're not resting enough to let the liver heal. As we mentioned, there's also psychological and emotional rest. It's as important as physical. We want to make sure that we limit environmental stimuli so that they can rest, okay? Limiting noise. And we also want to talk to them about utilizing organization and time management techniques to make sure that they have time to themselves and that they've got adequate time to rest. Diversional activities, because resting a lot, not being able to get out and do full force activity can be stressful. So we need to make sure that we use diversional activities like reading, other hobbies, to limit their anxiety and restlessness. So the same things that we talked about in the acute care area, we want to think about for home care teaching. Dietary teaching, we talked about high calories, adequate fluid intake, low fat if they can't tolerate it because lack of bilirubin, bile. Activity restrictions, we talked about gradually building up endurance, frequent rest throughout the day. And we want to talk to them about how to prevent transmission to others. So using a condom if they're going to be sexually active. What to report in the event that these patients have severe liver damage and they're having problems absorbing vitamin K and they've got some problems with bleeding tendencies. We want them to be on the lookout for indications of bleeding, like bleeding from their gums, any nosebleeds, dark tarry stools, or obviously signs of overt bleeding in their stools. And if the patients definitely progress to an acute severe form of liver compromise and they've got problems with buildup of ammonia within their bloodstream, we want to monitor for signs and symptoms of encephalopathy, irritability, confusion, somnolence, coma. So at diagnosis, these patients are encouraged to follow up for at least a year after diagnosis. They should not drink at all. We want them to eliminate all alcohol. Okay. A medication education, if they're on interferon, if this is a chronic hepatitis B or hepatitis C patient, we want to talk to them about administering it sub-Q, how often, technique, and some things to look for at the insertion site. Side effects, and I'm going to refer you to the handout again or your textbook. Flu-like symptoms, injection site, irritability, redness. And we also want to think about non-drug techniques to manage nausea and vomiting, headaches. So relaxation techniques, distraction, guided imagery. So all of those natural, more homeopathic remedies. And we want to make sure that patients who HBV or Hep C positive, chronic, that they can't donate blood. So our expected outcomes with these patients, obviously, adequate nutritional intake, that they adhere to their prescribed diet, that they're going to meet their nutritional needs. They're going to demonstrate a gradual increase in activity tolerance, perform daily activities with rest periods, and we want them to be able to discuss methods of transmission and prevention of hepatitis, and we want them to follow precautions to prevent the transmission.